All right. In preparation for starting, I'm just going to say a couple of words thanking the Pan American Trauma Society and the American Association for the Surgery of Trauma. This is our monthly joint collaborative international case conference. Just to place it in reference to the history, the Pan American Society has organized this by Dr. Antonio Martos for over 13 years, and the AAST has had the privilege to join with the PTS once a month. In the future, there might be other societies that might join in a more thematic sense. So, for example, the Chest Wall Injury Society might join once a year to, in a theme, promote chest wall injury care. But for now, we are the two societies. And again, Antonio Martos has organized this for many years. And I'm going to defer to our two moderators, Dr. Danielle Ricarte and Dr. Carlos Mendigoso. Gentlemen, the floor is yours.
All right. Well, thank you for that. If I may, I'll just do a brief introduction. Our presenter today will be Dr. Koesarie. She is from Conmel Memorial Medical Center in Pennsylvania. And a big thank you to her sponsor as well, which I believe is Dr. Jennifer Silvis. From the AAST side, we have Dr. Sabrina Asturias from Guatemala City, who is joining us as an expert panelist, as well as Dr. Colette is going to serve as a de facto last-minute panelist for us. Unfortunately, Dr. Jose Diaz was not able to join us due to last-minute commitment. And then if you want to introduce Dr. Rodriguez, though I'm not sure that he needs much of an introduction from the PTS side.
Yeah, sure. So we're thrilled to have from our side Dr. Aurelio Rodriguez, who is former professor of surgery, University of Maryland, and he's former co-director of Shock Trauma Center. He's also a member of the ACS Academy of Master Surgeon Educators and also co-founder of the Pan American Trauma Society. So that's why we're really thrilled to have him with us. And we are having a presentation from Dr. Kevin Petersen, who's a second-year fellow of acute care surgery in the Kerkorian School of Medicine at UNLV. And also Dr. Cools is also with us for this presentation.
Yeah, Dr. Menegos, let me add you something. This is very nice to have University of Nevada UMC hospital presenting. We're going to have the Formula One race next week in Las Vegas, and they have been fundamental for the race. They're participating and they're going to be with us taking care of the drivers. So it's really, we did this last year, doing this year again to show their commitment for trauma in sports, and just to highlight the great fellowship that they have, the great trauma service that they have. They're going to be working with us in the race next week. Thank you very much for everybody from University of Nevada, UMC for joining or for presenting today. Thank you.
Dr. Koesarie and Dr. Petersen, if you guys have never been a part of this, our goal is to try to get through each of your cases in half an hour or slightly less. We will try to interrupt. Myself or Dr. Mendigoso will interrupt and just ask our senior panelists some questions about the management. But again, the point is to try to get through both cases each half hour. Dr. Koesarie, the floor is yours.
All right, wonderful. Thank you. Let me go ahead and share my screen. Okay, can everyone see my screen?
Yes.
All right, wonderful. Thank you so much for having me. My name is Kathleen Koesarie. I'm one of the third-year general surgery residents at Conmel Memorial Medical Center. This is our hospital here. We are a level 1 trauma center in Pennsylvania. This is us in Cambria County. This here, my mentor is Dr. Dumeier and Dr. Silvis, who are both here with us. Dr. Dumeier is the chairman of our general surgery department, and Dr. Silvis is my assistant program director for the residency program. So this is us in Pennsylvania in the Northeast. Conemaugh is right here where the red star is. We do have 2 level 4 trauma centers, Conemaugh Miners and Nason, that are also starred here. But this is the general area that we cover. As you can see, a lot of this in Pennsylvania, and the gray color is mainly rural areas, and then the more urban centers near Philadelphia and Pittsburgh in the red. But we do get some of the patients close to Pittsburgh as well. I have no disclosures as a third-year resident, so we'll go ahead and get started with the case. So our case is a trauma alert for a self-inflicted neck stabbing. It's patient RH, he's 75 years old. He arrived at the trauma bay as a self-inflicted stabbing and slashing to the neck. There was reported significant blood loss, but we had no medical history or information from him. This is our trauma bay here. He arrived on a backboard, he was very combative, and his neck was immobilized with a towel. There were no pre-hospital vitals at this point. There was no access by EMS. We quickly placed some peripheral IVs and a right tibial IO. EMS was very astute in bagging actually over the open tracheal wound. And our EMS or our ER colleagues actually placed an emergent 8.0 ET tube directly into the opening in the trauma bay pretty quickly. The patient was agitated and ripping at lines. He was given 200 milligrams of IM ketamine and 100 of IV rocuronium, and other bleeding was controlled with direct pressure. This is not our patient here. Our situation, everything was happening very fast. No photos, unfortunately, but it was very similar to the photo here. As this photo is one single large laceration, our gentleman had stabbed himself multiple times in the neck. In the trauma bay, when we finally had some vitals, his blood pressure was 146 over 116, heart rate was 112. We placed an emergent left femoral cordis and 1 unit of whole blood was transfused. He was somewhat hypotensive after sedation. There's no record of the vitals as things are moving quickly, but I think someone said maybe in the 90s. So obviously a lot of blood loss, transfused the whole unit of blood and needed to get to the OR stat. No other obvious injuries. His pupils were reactive, and upon arrival to the trauma bay, he was moving all extremities. So we deferred, of course, any imaging, going straight to the OR, and an EFAST was negative.
Can I pause you there for a second? Just ask our panelists, Dr. Koesarie, I'll start with you. From your experience in Guatemala City, do you guys do anything different? I see obviously 1 unit whole blood was administered. Is that something you guys are using there? Your thoughts on that? And would you guys have done anything sort of different in the trauma bay as things are unfolding?
No, I think, we would not have had blood, like easy access to blood we do not have. So everything else we would have done probably the same. We don't have intraosseous access either. So we would just sort of had like the peripheral access and the vitals, and obviously that we would just have like placed the tube just like you see in that picture as well. Since we don't have blood, we would have obviously just given like IV solutions, salines.
Dr. Collette, I see the neck was stabilized with some towels, it seems. Your thoughts on penetrating trauma and stabilizing the neck or immobilizing the neck?
In these situations, I think the patient needed stabilization of the neck because it's anterior and stable on the neck. The patients have a secure airways and then blood for the injury. The patients is obvious go to the OR immediately to treat these injuries and try to make clear that the problem stop bleeding on the stop and control the airways. So I think important. What to do, I think I go to discuss next. What to do with these injuries, how to treat these injuries. But I think I have a case like this that very similar that may be the Glover know has cut the injuries in front of her mother in the neck. The patients may be from other country and then go to us by injuries like this one.
Dr. Koesarie, Dr. Pasquale is wondering, sorry, if the stab wounds were all in the neck, front, back, side. Can you clarify that a little bit for us?
There were multiple stab wounds and all of them were in the front. Everything was in the front, nothing on the side or the back.
Okay.
So not as extensive to the lateral portion of the neck, as you can see in this picture, was mainly, I would say, from here to here.
Can I ask a question? Okay. Was there any like signs of vascular injury?
So I wasn't in the trauma bay when this occurred, but it did appear that it was mainly venous bleeding, and I don't believe they were suspecting any carotid artery injury at this point. So nothing that was shooting out it by any means, but everything was able to be controlled with pressure.
No expanding hematoma then.
No
Okay.
expanding hematoma. There was a lot of blood and chaos, of course, and they just basically held pressure and on their way up to the operating room.
So correct me if I'm wrong, it looks like from here you guys went directly to the operating room, is that right?
Yes.
Dr. Rodriguez, I wanted to ask you your thoughts. It looks like, at least from the vital signs that we see on the screen, the patient was relatively stable. Assuming that that's the case, your thoughts on going to the operating room directly versus stopping by the donut of truth?
What are you talking about, CAT scan?
The CAT scan, yes.
No, oh, well, I mean, if we follow this for medical students listening or residents, when it has stopped penetrating with the neck, the first thing you think you're going to control if it's a bleeding, and second, the aerodigestive part, right? In this case, it seems like it's no bleeding, but I can see for some reason. And second, there is problem with the airways. The airway, in this case, there is no role for, this is the hard, soft sign, hard sign. This is a hard sign because the airway definitely is compromised. So in this case, I think this patient needs to go to the OR. The question here, I think you mentioned something about how to put the neck or control the neck. I think it's very rare in stab wounds, according to the literature, the association with, in these cases of injury, stab wounds can have a neck, broken neck, unless he fell, in the stairs, something like that is possible. Number three, in this case, there's no case for it taken to the CAT scan, because this is a definitely what do you call it, hard sign. This is an extremely hard sign. It's a completely hard sign. So this patient had to go to the OR. They mention sometimes, well, if the airway is not compromised, to trying to intubate the patient in the OR better than the emergency room in this case. But they did a good intubation here. I know that people there in Canemo. And I want just to make a comment to the lady who make a commentary from Guatemala. Are you from San Juan de Dios or Roosevelt? Which hospital?
Trained in San Juan de Dios with Napoleon Mendez, and right now chief of Roosevelt Hospital with Dr. Siguantay.
No, what I want to emphasize this is because if somebody wants to learn how to do penetrating trauma, you go to Guatemala. They see penetrating trauma not once a year, they see penetrating trauma every hour. So that's why I want to make the point. Thank you.
Thank you so much, Dr. Rodriguez. But yes, in this patient, we were not suspecting any cervical injuries. He was bleeding enough that, of course, this is still a hard sign with the injury. It's zone 1, at least zone 2 neck injury to proceed to the operating room. We did not feel that a CAT scan would yield any significant information, and we already had our obvious injury. So we proceeded to the operating room. On our way to the operating room, we secured the endotracheal tube with umbilical tape. Thankfully, our ORs are right above the trauma base, so we only went up 2 floors with the elevators. It was prepped into the field. This injury was essentially an incomplete decapitation, is the best way to think about it. He did have multiple irregular lacerations to the neck. Upon exploration, over 90% of the trachea circumference was violated. The first things we noticed in the OR that
Dr. Koesarie, can I pause you there for a second? Dr. Collette, if I may, your thoughts on, you're in the operating room, prep wide, do you go through the same wound? Do you expand the wound? What are your thoughts on that?
I think these patients, maybe if you have injuries like transversal injuries, you can use the incision that they made by the injury and stand it and start the retail, the skin and the muscles, and see the structures, explore the area. And then in this patient, I think it's important to know where is the trachea injuries, on the first, the second, the third ring, or not. If you take 9% of the trachea injury, you can try during the surgery to put oral tracheal tube during the surgery, take off these injuries and treat the tracheal injuries. So the trachea with possible, and to avoid a tracheostomy in this case. Sometimes I think it's very important. And you can explore the carotid bilateral. You can show, because sometimes you have injuries, and you can see the esophagus. Sometimes maybe problem esophagus injuries, digestive injuries also. So in these situations during the surgery, you can explore and can call for endoscopy and see the esophagus. But I think in these patients, maybe probably you need a bronchoscopy to put endotracheal tube for oral, and then expose the trachea and then treat the trachea. If all very near the larynx, the cricoid injury also may be injured. Sometimes you need to make tracheostomy.
Dr. Asturias, I know you mentioned blood was difficult to get to. Does it change when you get to the operating room over there? And if not, what do you do in the meantime, knowing that the patient obviously can't live off crystalloid forever?
I know. That's a really hard question. It's sad, but we barely have blood. Every day we get a memo of how many blood units we can basically like count on for that day. So if he's lucky, then yes, we would be getting in around 45 minutes to 1 hour of the patient coming in, rolling in. We would get maybe like 1 or 2 units of blood. We do tranexamic acid, and we do have that, and that's what we place at the moment. That's what we would have done instead of blood, and then colloids, and then obviously, you know, like cross your fingers to see if we have some blood for them. But yeah, we have to prioritize who we give the blood to, because we have like 20 units for the whole hospital. I'm talking about like onc and everything. So maybe he would have gotten 1 unit 1 hour after rolling in.
Dr. Koesarie, if you want to continue, just as an FYI, Dr. Mayer, who I believe is your mentor, says that they could look directly down the esophagus through the wound. So I think that's important to add. Go ahead.
Yes. No, it's important that you mentioned blood. We are lucky. We usually have 2 units of whole blood in the trauma bay, and then we have additional blood that's nearby, and we can activate MTP. I know that's not available everywhere. TXA is something we could have considered, but we did not give it to our patient. Proceeding to the OR, like I said, we did see multiple regular lacerations to the neck. We noted that he severed his bilateral anterior jugular veins. These were clamped and ligated with 0 silk. This is where most of the bleeding was coming from. There was also bleeding from the muscle belly. This was cauterized with Bovie electrocautery. And at this point, large volume hemostasis was achieved. And just again, communicating with anesthesia throughout the entire case. So establishing a good airway was the priority. Of course, that's why we ran to the OR with that ET tube secured in place. So the injury itself was at the laryngotracheal junction, so it was higher. And we knew we needed to place a surgical airway. So lower down, palpated the second tracheal ring and essentially placed the trach. And it was a 8 French Riley that was placed. So we secured that with a 2-O-proline, and then we brought our attention back up to the neck wound that was above where the tracheostomy was placed. Intraoperatively, he did receive 1 unit of PRBCs.
Can I pause you there for a second? Dr. Rodriguez, thoughts on the approach, and would you have done anything different? Would you try to explore with the ET tube in place and retracted?
Well, I want to ask a question. I know in that hospital, I was 2 years there, there is you talk about Canemo, right? Canemo. There is a X-ray plate underneath the bed inside, okay? And normally, they call you in advance that the patient is coming. It's almost like shock trauma in Baltimore. You know in advance it's coming, and probably you know what kind of injury it has. Even the attending, who sometimes is in the middle of the night, can live 5-10 minutes away, is already there. So you didn't do a chest. You see, they have stab wounds in the chest. You didn't think do a chest X-ray because it takes some. The X-ray technician is there also. I know, with the dinosaur ready to do an X-ray. So you didn't think to do a chest X-ray just in case. Trust no one. You know, in trauma, you don't trust even your mother.
So no, we did not do a chest x-ray.
Okay.
We did not have any chest injuries. Everything was focal to the neck. There were multiple stab wounds
Okay.
that were all very close together.
I thought you said there was something in the chest. Okay.
No chest injury.
Okay. Yes, I agree with the doctor from Brazil. I never can remember your name. I'm sorry, my friend. Said that I could try to investigate if the airway is controlled in the OR, trying to investigate with the bronchoscope, is any other injury more proximal or distal, and also the esophagoscopy. There is a high incidence of association, obviously, between tracheal injuries, esophageal. You have to rule out somehow, unless the patient has some food from Christmas or something is coming out through the neck, So anyway, I agree with him where we're saying I didn't add anything. I just want to be sure. I misunderstood. I thought he had many stab wounds in the chest.
Yeah, no problem at all. Thankfully, no chest injury, just the injury to the neck. And it might have not been clear in my earlier slides, but again, when we did give the ketamine and the rocuronium, he was unstable enough to not stop and get the chest x-ray, and we proceeded directly to the OR with him being so unstable.
Just to make a discussion, I ask him, do you establish in this case it was an indication for the protocol, we have the protocol for transfusion protocol. Do you thought about that or no? You don't think it's necessary? Just make another discussion. I'm sure the resident want to know about it.
I can't remember, there wasn't documentation, but I do believe a mass transfusion protocol was initiated on this patient. But again, we had the blood available right in the trauma bay that was running on the way to the operating room. And they did, I believe, pull some labs and a trauma gas in the OR. It was bleeding in the OR slightly, again, mainly venous bleeders, and he was given PRBC intraoperatively, but he was stable after that point.
Thank you.
So in the operating room, thankfully for this gentleman, he avoided his carotid sheath entirely on both sides. He did have, like I said, 90% of the circumference was injured. And what's important is that there was only a small layer of posterior trachea mucosa that was left intact. So the esophagus was not touched. This gentleman was very lucky. The esophagus was completely uninjured. So again, we established our airway lower down. We're up at the wound. Hemostasis is generally achieved at this point. The trachea was debrided, non-viable edges, and any cracked cartilage were excised. This was all primarily repaired with a 2-0 PDS in simple interrupted fashion. Of course, we avoided any knots on the inside to avoid granuloma or any possible stricturing or stenosis in the future. The strap muscles were then reapproximated, and that was placed over a flat drain channel. So we could assess later for potential leak. We did wash him out with Eriseptin saline, and everything after that was closed in layer. So the platysma and then the skin. So just a note on tracheobronchial injuries, this is very rare. This is a unique case. These injuries, blunt and penetrating, are very low, and incidence is from 0.5 to 2% of all traumas to the neck and chest. With blunt injuries usually closer to the carina, whereas penetrating are usually higher up, as in our case. The incidence is unknown, as mostly 30 to 80% are estimated to die on scene, but our traumatic tracheobronchial injuries have decreased from about 36% in the 50s and this 30% in the 60s to about 9% in 2001. So
can I pause you there for a second? Sorry, I just wanted to go back to your case for 1 second. Dr. Asturias, I know obviously we talked about blood. What is your capability of doing endoscopy intraoperatively? And if not, based on what you're looking, do you explore everybody's esophagus? How do you approach that when you don't have endoscopy readily available?
Yeah, we don't have endoscopy nor bronchoscopies. So yes, we explore. We obviously, like this patient, obviously we would have explored. We do not explore every single patient that, it comes stable and that comes stable and that we don't like highly suspect any injury. So we do some, a little bit of conservative management, but we don't have endoscopy, so we do it without that. If we suspect, and we want to keep the patient like conservative, he's stable and everything, we do the hydrosoluble drink, like swallow to, that's what we have. So that's the only way that we can manage it if it would be in a stable patient. The esophagus, no endoscopies, no bronchoscopies, no x-rays on the table either. So everything is explored.
You know,
Everything is visualized.
It's very interesting to call the attention to the young residents here. The first place, I'm jealous. In 2 years I was there, I never get a patient a case like this. You know, I love it. And you have Dr. Dumeyers, the director there, who is a fantastic and knowledgeable guy who could be chief of trauma and shock trauma anytime, you know, in Baltimore. Okay. I want to emphasize to the residents that how is surgery taken care in other countries, except in Cali, Colombia, where Dr. Ordóñez has more than the Mayo Clinic, you know. All the other hospitals don't have, in Brazil, perhaps. Okay. Brazil is very close to America, you know. Brazilians, the only thing in common have with Latinos is soccer, but they are very American thinker, you know. They think different, they are different, they are not the same. They do two things, they do soccer and have fun, right? We have that something in common, the rest is not in common. But I have to tell you that in the rest, there are many hospitals in Latin America who don't have all these facilities we have in other countries, you know. It's a different type, and it's amazing the outcomes they get with almost nothing. It's just pure technique and pure capabilities.
Dr. Collette, one of the questions that was asked is, and it sounds like from the case description, there was not a lot of tension on the trachea once the debrided tissue had been removed. Any pearls of wisdom for when there is a lot of tension, how to approach those injuries when there is significant tissue loss and the edges are not coming together nicely?
You can relax the ligaments upper on the larynx, then trachea can go down, and sometimes you have to make some thoracoscopy and cut the pulmonary ligament, then the trachea can be go up. There is some maneuvers that you can enhance to approach the trachea. I think it's only these injuries that you have injuries by knife, injuries. Sometimes the debridement is very small and the trachea can be very easy to and close is by suture. The great problem in these situations, I have mentioned that you have endoscopy. If you don't have endoscopy, you can evaluation during the surgery, and then you don't have to put a drain, and then go in the postoperative evaluation the patients with a swallow of contrast, and then there is fistulas or not. But I think it's not very difficult to explore during the surgery. The great problem when they have a big injuries on the trachea, it will make possible to have injuries of laryngeal recurrent nerves. It's a problem by the extubation on the end, because the laryngeal recurrent nerves run between trachea and esophagus, and sometimes these injuries may be cut this nerve and may be problem with vocal cords. Not usually, but you can think about this. That's a great problem when you have injuries in this area in the trachea.
Yeah,
remember this.
One of the things we talk about technique here, technique. In the first place, the injuries in blunt trauma, that's what was mostly shock trauma, blunt trauma, was due to the famous hanging of the clothes, the hanging, those cords that people hang the clothes, you know, and the motorcycle go and hit that and cut his trachea. This is not a common injury in blunt trauma, obviously. And one of the technical things, you have to be very careful. In addition, my colleague from Brazil said, you know, that the circulation of the trachea came from the side, enter from the side of the trachea. So you have to be very careful, don't to keep cutting, trying to peel in the trachea to be good, because then the trachea is going to die because you're cutting all the circulation of the trachea. So this is something important. And regarding the closing of the trachea with triovicryl, that's what they recommended, non-absorbable, you know. However, I have done few repairs of trachea that I repaired with Trolene because of even in shock trauma, there was no vicryl when I asked for it, you know, and I repaired the nuts has to be outside. She emphasized that. That's very important for the resident. The nuts has to be outside, ideally. Sometimes you can, but ideally, otherwise you get a fibroma or something like that, it could bleed. And I think that The problem, yeah, there is a circumstance in the trachea injury is very close to the thorax, it's very low, you know. In that case, you could end it having to have a small middle sternotomy. I never have done that, but that's described, you know, where you have to pull on some hooks. Yeah, the trachea, there are hooks to pull it up, you know, to be able to suture. Hopefully not too tight, but the hooks are very important, you know, sometimes to pull the trachea who is underneath to pull it up. I never have to go to the carina and those ligaments that he's talking about, my colleague from Brazil, you know. Maybe the Americans don't have those ligaments. Anyway.
Dr. Asturias, final thoughts on this case, anything you would have done different or any pearls of wisdom from your side?
Well, actually, we would have done exactly the same since the patient came in. We would have just thought about the airway, no CT scan, no blood. That's the only difference. But we would have gone immediately to the OR with this patient. And we would actually have done the same thing, that we would have repaired the injury that was basically like higher up and then placed to the trach tube under, you know, like lower the injury, not through the injury, never through the injury. We try really never through the injury. Sometimes you just can't when they're like gunshot wounds. But we would have placed it in a different place. And since there was no bleeding and, you know, the carotids were fine and you can actually visualize the esophagus, I think that's what that would have been like the case. We repair with Vicryl, just like Dr. Rodriguez said. Well, I think that we would have, there's no difference than what we would have done about here, actually.
Well, thank you for that. And Dr. Koesarie, thank you. We're going to move on to our next case. Dr.
Can I ask something
Yes.
very, very important here? You say you did a tracheostomy in this patient, right?
Yes.
Yes.
That's the question should be discussed, because there's a controversy about, you know, you need a tracheostomy, you know, a proximal tracheostomy. That's what you did, right? A proximal tracheostomy?
Correct. Yes.
Okay. Well, there's a controversy about that. And also there's a controversy that you repair them primarily. They want you to take the tube out very quickly. They don't want to keep the tube in when you do a repair. How long you keep the tube there? Oh, you did a tracheostomy, right?
Yes. So the ET tube was brought up from the emergency department. And again, the injury was higher up. So it was at the laryngotracheal junction. So we placed the tracheostomy lower towards the second tracheal ring.
Yeah, the reason I'm asking this question is because I always did a tracheostomy, the one I did, but I read the literature recently that, you know, I have more time. I'm retired, so I have time to read. All these people who write these things that now they don't want to put a tracheostomy before, you know. And they say, oh, really? You know, I wouldn't go to sleep, you know, happy if I don't do a tracheostomy. It's a primary repair, and that's it. The doctor from Brazil, very, can you say very briefly, you use the tracheostomy, yes or no?
So, Aurelio Rodrigues, here in Brazil, the first approach in injury of the trachea is try to primary repair. If you don't have conditions for primary repair, you can put a tracheostomy. Tracheostomy may be another hole in the trachea if have another injury. So I think it's very important to know that tracheostomy is not the priority, maybe repair the trachea. And I think it's very important to know that for suture of airways of trachea, you have to use absorbable Vicryl oil. Don't use inabsorbent not use that, no absorbent. You have, if I have used no absorbent skill, you can have granuloma in the trachea and maybe problem with this. You frequently the suture of the trachea, you have to use absorbable skill. Okay.
Dr. Colette, the final question for you. You mentioned primary repair, try to avoid the tracheostomy if you can. When would you extubate the patient? If the patient's stable, would you do it at the end of the case or would you keep it for a few days?
Usually, I think the patients may be stable. You can see the trachea if the patients have no edema or the neck. So you can try to make take the extubation of the patient. Probably in this situation, when you have sometimes you have suspected that may be recurrent nerve injuries, you have to ask to have a bronchoscopy to see when you try to take off the tube. It can facilitate the intubation if you need. But I think usually you wait 2 days to have the patient have normal ventilation. You can try to stubation the patient.
I appreciate that, Dr. Koesarie. We're going to move on to the next case, if that's okay with you, just for the sake of time.
No,
Since
absolutely. I just wanted to let everybody know, thankfully, just going quickly through the slides, he did get discharged on post-op day 28, and he was actually decannulated and is actually able to eat now. Talked to his wife earlier this morning. He's doing wonderful. And thank you so much for having me.
appreciate you being here. Dr. Menegoso, floor is yours.
Yeah, thank you. Great case, Dr. Kathleen. Very interesting. So we're going to call Dr. Kevin Petersen to present his case. As I said earlier, Dr. Kevin Petersen is a second-year fellow of acute care surgery in Kirk Kerkorian School of Medicine at the University of Nevada, Las Vegas. So Dr. Kevin, feel free to start your presentation. Dr. Kevin, you're muted.
Bear with me as I'm trying to.
Yeah, now it's working.
Presentation.
Okay, no problem.
Sorry, Dr. Colette. Now I know the name. I try to remember. Remember, I'm 81, so I have the right to forget things.
Carlos, I don't think he heard you.
Okay.
Did you find your share screen there, Dr. Kevin?
I'm trying to share it right now, and there we go. I think I can share and
Yeah.
pull up the PowerPoint.
Yeah.
Can everybody see that now?
Yeah, we can. Perfect.
Great. Okay. Like I said, good afternoon, everybody. My name is Kevin Petersen. I'm a second-year acute care surgery fellow here at University of Nevada, Las Vegas. I'll be sharing a case with you today. Disclosures, I have noted personal disclosures, and consent was obtained from the patient prior to creating this case presentation. So this was a Thursday morning, approximately 10:30 in the morning. Rounding with our trauma team, we get a full trauma alert. We are told that it's an inbound penetrating injury patient. This patient was coming from about 150 miles away in Havasu, Arizona. It was coming from rescue flight. The reports that we got was that the patient was hemodynamically stable, and they'd be here within 20 to 30 minutes. For us, this is kind of a run-of-the-mill Thursday morning. We were preparing our trauma bay for accepting this patient. Little did we know that this was what was on our way to us. Are you guys able to see the picture? So as you can see, the
Yes.
patient had a significant penetrating injury through his neck and through his left arm, which really wasn't described to us when he was when the initial report came in. But life flight arrived with the patient, and the rest of the report came that he was a 48-year-old male. He was working at a construction site. He was approximately 20 feet in the air on a second-story building. He was not harnessed because it was only a second story, apparently, and he fell backwards onto exposed rebar. It was a prolonged extrication because they had to wait for resources to get there to cut the rebar to free the patient from the structure and be able to airlift him in. He was hemodynamically stable throughout the entire time on site and actually in flight as well. The aircrew was very concerned about his airway given the location of his injury, but he was able to maintain his airway throughout the time of extrication and the flight. And so we started with the patient. I was curious, my questions are priorities of management. Following ATLS protocol, we followed our primary survey, evaluated his airway. The patient was unable to phonate, but he was obviously passing air and attempting to phonate. Listening to his chest, we heard breath sounds bilaterally, equal symmetric chest rise with each breath. He did have 2+ pulses throughout, importantly noting that he did have positive pulses in his carotid and his left upper extremity. When we fully exposed the patient and looked for disability, he was moving all extremities, able to follow commands. He was given a GCS of, I believe it was 12 because taken off for phonating. He was able to follow every other command that we asked him. And on exposure, we saw that he had this penetrating rebar that was basically at his temporomandibular junction, with maybe about 18 inches of exposed rebar from that component, and then an additional exposed rebar in his left chest that you could see on the prior picture there, and the arrow in that picture to the right. You can see the arrow. There was the exposed rebar from his left chest. It was basically the anterior axillary line right around the area of his nipple line. He also had this additional piece of rebar that was in his left arm that you can see on the same picture. It looked like this was just a through and through injury of the subcutaneous tissue there, that he had sustained. So we, as part of an adjunct to our primary survey, we got a chest X-ray. We were surprised to see that it didn't look like he had any pneumothorax or hemothorax at that time on that chest X-ray. And we continued with our secondary survey and did not find any other injuries that the patient had other than the obvious ones that I've highlighted so far. So our thought process was where to next. In evaluating this patient, we see that he's a hemodynamically stable patient. We had a large bore IV access, but he was actually hypertensive and tachycardic when he arrived to us. Our main concern, our main focus still remained the airway. He was maintaining this airway, but we were questioning how happy we were with this airway at the time. We discussed any immediate procedures that were needed in getting this patient, particularly in moving the patient, and thought about anything that we had to get done right there in the trauma resus room. And then we also considered collaboration at this point. Who else do we need to have there? Luckily, here at UNLV, at our full trauma codes, we have anesthesia present at bedside. And so they were able to evaluate the patient's airway, and they had the same concerns that we did. We were happy that he was able to maintain the airway. At this point, he had it for approximately an hour and a half between the extrication time, the transport, and our workup and our trauma resus. So I guess my questions are, anything that the panel of experts would be considering before moving this patient on to either further diagnostics or any other workup that you'd have?
Yes, that's great. So Dr. Rodriguez, let's start with you. So what about the airway and additional workup?
Yeah, the first thing for the residents, one thing I used to teach everybody there, said, in this kind of impairments or injuries like this, one thing you don't know, put your cowboy boots and trying to pull it out this in the emergency room. That's more important than everything we're going to say, because in some place somebody's going to try to pull it out. You have to. I know you didn't think in Las Vegas, they don't think that way, but everybody else, there are other places probably somebody will say, hey, let's take it out. No, don't take it out. You have to establish an airway. It seems like he has an airway, right? Seems like he has an airway.
Yes, sir. He was managing to maintain his airway on his own.
It seems like he is not need to be nothing bleeding that you have to stop bleeding. So this patient got to go very carefully. I don't think this is going to be able to go to the CAT scan. I don't think these people will fit in the CAT scan. So they have to go to the OR. At that time, you were thinking, why me? Why I'm having this case? Because this is not an easy case for anybody. You're going to tell me now, oh, no, yeah, we see this every night in Las Vegas. See, but no, this is a difficult case any place you go. Now, what are you going to do with this guy, And you have to figure out what is the trajectory of this thing. Within this case, it's not like the coins, because the coins don't follow trajectory, but this is a trajectory here. You know where exactly they pass. The thing you don't know is what hit in the trajectory, and that's the question. So I don't know. I think take him to the OR and start thinking what I'm going to address in this patient, what I'm going to open. Is anything to open here? Or I start thinking, I still not completely sure what I'm going to do.
Great. Dr. Sabrina, assuming that the patient wasn't maintaining his airway on his own, how would you approach this patient? And knowing that the patient was trying to phonate before, and he wasn't able to do it. So would you do what strategies would you assume here in this case if you needed to get an airway?
Yeah, I think we would have intubated. We would have intubated this patient just because he could not phonate. We didn't know what was happening. Like obviously like the any kind of hematoma or anything that was affecting his vocal cords would have been really. We don't have anesthesia like bedside. So I think before he would have gotten like more complicated, I think we would have probably intubated this patient. And considering that he's going to go to the OR anyway, I think we would have probably intubated that patient immediately to protect his airway. And then my question is, maybe did you consider a lateral chest X-ray? Just asking, or do you have it?
Actually, I don't believe
is that
we took a
possible?
lateral chest X-ray. It is possible. I don't believe we took one at that time. No, I don't think we have the lateral chest. That is a very good idea to identify kind of the trajectory of the injury and where it was within the chest. I think we felt pretty confident that if this rebar had passed through his chest cavity, we would have seen something on the chest X-ray, pneumothorax, hemothorax, or even significant rib fractures, which were not present on that prior chest X-ray. I can go back to the image too. There you go.
Yeah, just to confirm that it was like passing posteriorly. We do that, when we see gunshot wounds and we don't know, like if they are like why there's no pneumothorax, we do that just to see if sometimes they're in the posterior in the back and the subcutaneous tissue in the back and they look like they're in the front. So it was just a question. It was just, a question of to confirm.
Sure, Dr. Frisbee.
What did the anesthesia people, when they put their scope in there and looked at his pharynx, is that rebar behind? Is that posterior to his pharynx, or does it go right through it?
Yeah. So I'll continue with the case. So what we did was, I can get to that, Dr. Frisbee. That's a very good question. So anesthesia actually did not do a direct laryngoscopy at the time in our trauma resus. They were happy with him being able to maintain his airway at this point in time, and we had decided actually to continue to CAT scan. But Dr. Rodriguez, your point of him being a difficult patient to move, that rebar in his left arm was very sizable. We took an X-ray of his humerus, saw that there was no fracture site there. He had a good pulse in his distal radial artery. So we felt confident that it was just through the subcutaneous tissue to help in the movement of this patient. We actually cut straight down to the rebar and removed that piece to take it out of the element of moving this patient. And so we only had the rebar that was sticking out of his right neck and his left side of his chest. So we actually continued with the patient and brought him to CAT scan and decided that we would take the time to scan his head, do a max face, a CT angiogram of the neck, as well as a regular CT scan of his C-spine. We also did chest, abdomen, and pelvis because of where that exiting wound on his left lower chest was. And so I've got some images here that kind of highlight what we're looking at. As you can see on this left lower image, this is the right side of the patient as the rebar is entering. It's right at that temporomandibular junction. You can see the scatter from the rebar. And its close proximity to the carotid artery as it enters into the base of the skull. The middle picture on the lower aspect of the slide, you can see the rebar, and it's directly in his posterior oral pharynx. The right side of the picture, the lower right side, you can see that's the left neck with its close proximity to the common carotid. We identified that this was actually on the top right. You can see that the rebar actually passed above his larynx and above his trachea, but it was within the middle of his posterior oropharynx, which we were able to kind of identify here on these images with this patient. He had no injuries to his head, no other evidence of any fractures to his neck. And the chest, abdomen, pelvis show the following images. You can see that this piece of rebar basically passed completely anterior to his thoracic cavity. The pictures that I have on the top left, you can see that the rebar is outside the thoracic cage, running right alongside the ribs. You can see on the bottom left that it's just above the clavicle as it passes from the right neck into the left side of his chest. And the right-sided images show that there's no evidence of any pulmonary contusions or significant hemothorax there, confirming what we had suspected initially, that he didn't have a significant injury within his thoracic cage. And the bottom right is just the rebar passing the thoracic cage and continuing through the subcutaneous tissue as it leaves. Any questions about these images that I can answer right now?
So I'm going to ask Dr. Collet about this. Dr. Collet, so now that you have the CT scan and also the other images that Dr. Kevin showed us, considering he already took at least cut the rebar from the arm, would you consider taking this patient straight to the OR, or would you do anything different before, like an additional workup or something else?
I think this patient I took the OR, direct to the OR. I don't think you have you can see that they are carotid. There is no signs of injuries, so you can go to the OR. You have injuries of the neck, can explore the neck and the area when they cross the neck, and then the chest you have no injuries. Then you can take this the ribbon out. But you can see what happened, and you have injuries between the vertebrae and the hypopharynge or oropharynge, can be laceration, and this sometimes you can maybe repair these injuries and drainage. I think that's the way that you can do.
That's great. Dr. Sabrina, would you do anything different? Would you consider doing endoscopy or bronchoscopy before getting this patient to the OR? Or maybe, I don't know if you have in your hospital interventional radiology at your disposal to be ready for me sometimes a bleeding which is sometimes difficult to access from a surgical point of view.
No IR, but we do have, we would have endoscopy and bronchoscopy during the week and during the mornings. So yes, we would have probably scoped this patient before. We probably would have not had the CT scan done to this patient. So we would probably do the endoscopy before going to the OR. Like he's stable, you can, but he would have probably been intubated in my institution, because since he couldn't phonate, we would probably have thought of like some kind of inflammation that he will have posterior, and we wouldn't want him to have some kind of like airway situation during the night, maybe, like waiting for the morning to come to do all these scopes. So we would have probably intubated and then no CT, and then done the endoscopy, bronchoscopy, and then OR.
Perfect. And Dr. Deborah Cohn on the chat, she just noted that the CT scan in their service is within the trauma resuscitation bay. So that's why it seems to really, really quick to get this patient to the CT scan. Dr. Rodriguez, anything different from what the other panelists said?
Yeah, I just want to, but Dr. Kuhn, I think she is one of my favorite fellows for shock trauma, once upon a time. Nice to hear you, or you're here with us. I want to throw a controversial thing, We wrote the papers once upon a time that the resuscitation in shock trauma could be being made better in the OR than done in the emergency resuscitation. So here's the question. I think it's wrong that because the OR is not equipped for many things you can do in the resuscitation. The OR that the nurses are not prepared for, they are prepared for very specific things. So I personally think that resuscitation is better done if you can do it in the resuscitation area. But this is the question. This patient did a lot of things in the resuscitation area before taken to the OR, There was they contemplate the possibility the patient could require something emergency surgically, and you are in the resuscitation unit. I asked him that question. Can you answer that?
Yeah, so this is definitely was on the back of our mind of where this patient's safest. One thing that I do need to highlight that I'm sure Dr. Cool is hoping that I do is that along with our CAT scan within our trauma resuscitation room, our ORs are approximately 20 feet from our resuscitation room. So should we need to take this patient emergently to the OR, it's easy to roll them right into the room. So we told our OR team to have everything ready and start to open up stuff on the back table. We knew this patient was eventually going to end up in the operating room, but we went about it in a systematic approach because of his stability and his ability to maintain the airway at this point in time. So I appreciate your question there, Dr. Rodriguez. And it was something that we were contemplating, is when do we need to take this patient to the operating room? When is it safest to take him there? I think that the thought process was we want to, while we have time with his stability, we want to identify exactly where we need to attack first in this patient before bringing him there. And I think his stability gave us the time to work him up further in our resuscitated room with all of the adjuncts that we have close by. We also have, this is the 3D recon showing the bar passing just anterior to the thoracic cage. And our CT angio, like I said, didn't show any vascular injury. So as we talked, still concerned about the airway. We were obviously still very concerned about the airway. We did identify that there was not any immediate need to rush this patient to the operating room because there wasn't significant bleeding, there wasn't a significant chest injury. And so what we did at this time was we consulted our colleagues in ENT that were able to come down and evaluate this patient, knowing that he would need, a more secure airway. But we did not really feel very comfortable with just the CT angio at this point because of how much scatter we had on that imaging. What ENT was able to provide us was they came down and did a nasotracheal intubation using a fiber optic camera, and they were actually able to visualize the rebar passing the posterior oropharynx just above the vocal cords and the larynx, which would have made it very challenging to intubate in a crash situation, especially after giving the patient RSI medications. We were able to do this under while the patient was awake. We injected transcutaneous local anesthetic into his vocal cords, did a fiber optic visualization of the vocal cords, and passed an ET tube over there. But that ET tube was abutting and touching the rebar throughout this entire time, which allowed us a little bit more confidence in his airway at this point, but we still knew that we weren't through securing his airway. So after we had done the nasotracheal intubation, we wanted to confirm that there was no evidence of vascular injury. We wanted just reassurance before taking him to the OR, focusing on the airway. We also had planned on trimming down this rebar because we knew that he had about 18 inches of extra rebar sticking out from his neck. And we had planned on trimming that down. We wanted to make sure that we had 100% confidence that there was no vascular injury before doing that because of the vibrations and local effect that trimming the rebar would cause. So we involved our IR colleagues who shot a direct angio of both the left and right carotids. And you can see here on the bottom left, that's the right side of the patient's neck in the close proximity of the internal carotid that the rebar has. And then in the bottom or the right side picture, that's the left side of the patient's neck, and that's the common carotid there on the left side in close proximity. So after shooting the direct angio, we wanted to focus on removing the rebar and securing the patient's airway. And as I said, we didn't want to pass additional rebar more than what was necessary beyond his neck and beyond these vascular structures and his airway. So we incorporated our Las Vegas Fire Department to come and help us in trimming down this rebar. After lots of discussion with them, they had a circular saw that they thought would be able to cut the rebar. They didn't want to use what we call the jaws of life here, the pneumatic device that can cut this dense metal, because it puts a lot of torque on the item that it's cutting. So they thought the best course would be use this saw, which presented its own issues. We discussed whether this should be done in the operating room or in some other facility. Again, like I discussed, our operating room is very close to our trauma resus, and we have our own PACU as well that's within that 10, 20 feet to the operating room area. We didn't want to do the trimming of the rebar in the operating room because we knew it would create sparks and would be a risk of fire with the oxygen source in the operating room. So we actually did it in our PACU in a negative pressure room. And if you will allow me, I have a quick about 10 second video of them trimming this rebar, which is pretty interesting. The things that we were considering and concerned about was the rebar was going to heat up and vibrate in cutting it. And that was going to potentially have that direct local effect to his neck and his vascular structures. So we had cooling blankets that were soaked with cold water, and we actually had cold water that we were pouring over top of the rebar. We had draped the patient off with towels, and as you can see, the Las Vegas Fire Department was all kitted up and ready. So we brought him into his negative pressure room and proceeded with this. After that was done, we also had to grind down the edge of it because it cut it to very sharp edges after that. And you can see that in this middle picture, this was after the grinding, it was a smooth, rounded edge. With that being done, we moved the patient finally to the operating room. Excuse me. We moved this patient to the operating room. Our plan at this point was to do a definitive airway with a tracheostomy. We wanted to expose the bilateral carotids and put vessel loops around it. So we ensured that if there was evidence of an injury, we had that step already completed before removing the rebar. So we had ENT and vascular in the room. We did bilateral neck explorations and exposed the carotids. This was done after performing the tracheostomy below the level of the injury. That's a reinforced long ET tube that's in the patient's neck, providing us with an airway below the area of the injury. You can see in the left neck that that's actually the rebar as it's passing through their incision. And we had to dissect around the rebar in order to isolate the carotid artery. After we had this all, the vessels tied off with vessel loops, we had a secure airway. We felt confident that it was time for us to remove the rebar. I have another video here. So this is us in the operating room.
Who is pulling? Who is pulling? The attending, you? Okay. So they blame you. They put you to pull it in case.
Absolutely, Dr. Rodriguez. I wouldn't
move
pass up that
to attend.
opportunity, though. But after we removed the rebar, the ENT proceeded with repairing his posterior oropharynx intraorally. We closed our neck incisions over drains, and we changed the ET tube into a tracheostomy tube to further secure his airway. ENT did a direct esophagoscopy and did not show any evidence of injury to the esophagus as well. So we placed an NG tube for feeding access at that point. And that was the rebar after it was removed from the patient that we have there in presentation. Any further questions before I move on with the post-operative course?
So, Dr. Kevin, I think you can move on because we are ahead of time already. So I think you can just move on, close the case, and then we have a final round with the panelists.
Yes, sir. So good to end to the story. Post-operatively, he went to our trauma ICU. He was maintained on a ventilator for a few days, but successfully weaned down to trach collar and T-piece. He was sent down to the floor. He eventually went to the OR with OMFS. I forgot to mention that on the max face. The reason why he was having a hard time phonating was because his mandible was dislocated and fractured. And so he went to OR with OMFS after stabilizing for that management of his mandible. Within a few days, I believe about 7 days, they did an aqueous esophagram, which showed no evidence of any esophageal leak, confirming what we had thought in the operating room. And he was approved for PO. He passed his swallow studies. We downsized his tracheostomy and did capping trials, allowing him to phonate and swallow on his own. He was eventually decannulated, monitored for a day, and then discharged to home. He's got follow-up with OMFS, ENT, and trauma, and he seems to be doing well at this point in time.
Nice, very nice. So let's start with Dr. Rodriguez. Any final comments in this case?
The most fascinating case I haven't seen in 40 years, the sequence, that the decisions you make are almost perfect. You know, no, I wouldn't be able to do this. And just for the residents, when you have pellets, you know, like shotgun, the same situation like this, that all these are artifacts in the CAT scan, the next step is what you did, an angiogram, you know, is the only way you can rule out. But this is fascinating. Whoever was you attending, you know, it's fascinating, you know.
Thank you very much.
Don't put it TikTok.
Thanks, Dr. Rodriguez. Dr. Sabrina, any final comments?
I think it was amazing. Congratulations. You know, that was an impressive case, impressive save. It would have not been the case here in Guatemala from the beginning. It's, you know, we're learning, but the best we could have done was probably only, you know, like what I said, we would have intubated. And now that you tell me the conditions of the patients, we would probably failed. You know, our rapid sequence intubation would have probably failed but that's what we would have tried to do with our abilities and maybe with our experience, maybe we could have done that. We are the ones, anesthesia does not do, we do all the intubation and all the RCSI. So it would have been us, the trauma surgeons, and we would have done that endoscopy and bronchoscopy and then just, but I think the decisions of the exploration of the neck that you made, we would have done the same exact thing here. Like that decision, we would have done exactly the same. We've had a semi-similar case, but it was through and through, left to right. You know, it wasn't the whole. You know, it wasn't like that oblique. And we did the same. We found the carotids, you know, and like had the carotids without the angiogram though. Before, so we did basically like all the vascular and all that. And I don't think we would have done the angiogram, but just because we couldn't have because of. But we would have done that, and then. I don't know if the outcome would have been the same, but congratulations. That's an amazing case. It was very good decisions.
Thank you.
Good. Dr. Collet, any final comments before we close?
I think it's a very good case, very interesting case. I have one advice. When you have this level, it has a round. When you took it out, you can rotate it. Not try to push. You can rotate it and then it can go more easy. They can try. Sometimes I have some people have this implanted these injuries in other portion of the body, and when you try to pull it out, it's not come easy. But if you rotate it, it's very easy to take. It's a very good case, very nice case, very excellent resolution. Thank you for the presentation.
Thank you, sir. Yes, no, I was surprised at how easy that rebar was actually came out. I did not have to put much tension at all, and it came right out.
No lubricants. You didn't put in.
No, sir.
Excellent. Dr. Kevin, thank you very much for your presentation. Now I'll ask Dr. Martos and also Dr. Pascual if you want to make any final comments and close the meeting.
Thank you very much, Carlos, and again for a great moderation. We from the Pan-American Trauma Society are very happy with this meeting. We're going to have the last one of the month next month, and we have been very successful. I'm glad to see two great cases presented by residents, by fellows, and see the new generation moving up on this educational activity. Thank you very much, Dr. Pascual.
Yes, thank you. Great moderation, Carlos and Daniel. Every month we have different moderators, different panelists, experts from around the world, trauma centers from around the world, emergency departments, etc. Just so everybody knows, we have a joint acceptance with the SACO Journal, where excellent cases are selected by judges over the course of a few months, and then together with the panelists' comments, are going to be submitted for free of charge publication to the journal SACO with agreement of the editor-in-chief. So those are going to be options available in the future that Dr. Quarte has organized. And good luck for the presenters today for hopefully winning that award and then having that publication submitted. Thank you, everyone.
Thank you. Bye-bye.
Thank you all. Have a great day.